Good morning and welcome to and happy Black History Month. My name is Wally Elegbede, president of the Rochester branch of the NAACP, and we're really excited to have you here today. So I want to welcome you on behalf of the branch for today's event. Uh, Black History Month is a month about reflection, is a month about really sharing the achievements and the work of African Americans, and we're also, from an NAACP perspective, we also wanted to use this opportunity to really bring a series of really good events to the community to provide information about healthcare, information about COVID-19, things that we did last year, and also just opportunities and how do we want to move forward. So the NAACP, essentially, we advocate for social justice for all Americans. And when you look at it, a lot of important initiatives that are really important to us are healthcare, economic sustainability, criminal justice reform, jobs. And so, those are really critical things. Now, today, we basically brought in a lot of really top experts to really provide us with more information regarding to COVID-19 vaccine and testing. We're bringing in a lot of really top-notch doctors, industry leaders. And when you look at it, last year with COVID-19 affecting, a majority of Americans, the African American population has been severely hit. We're overrepresented in the number of COVID-19 vaccines and minorities, not just African Americans. And a lot of people in our community have expressed fears in terms of the distribution, and then also in terms of just the safety and efficacy of the COVID-19 vaccine. So, I encourage us to use this as a learning opportunity to ask a lot of really good, tough questions. We have top experts that can answer this information for us in terms of how to keep us and our families safe. So, I encourage you to really engage with us. Go to slido.com, and that's going to be a way for the audience to participate. So if you go to slido.com and you put in the NAACP Rochester MN code, that'll be a way for you to send your questions directly to the doctors and the physicians and healthcare leaders that we brought forth today. Next week we're going to continue our month-long series of Black history events with the Attorney General for Minnesota, Keith Ellison. He'll be joining us, so watch out for that. But with all that being said, we're going to have two moderators that are going to really help us out. So the first person that's going to be moderating this event for us is Donovan Bailey and also Rachel Schneider. So I'll just give a quick update on Donovan and Rachel. So a lot of you in our community, know Donovan as the person that ran for city council, formerly on Barbershop Talk, and also having his own podcast and doing really great stuff. Donovan, he's also a licensed social worker in Minnesota and Colorado, and has served in this capacity with Minnesota's Public Defender Office for the past 13 years. He's trained in Dr. Deidre Hawkins' One Small Change program, and he is also a cultural competency facilitator. And his past work experience includes being a youth counselor, a police officer, a residential treatment supervisor, and he served on various committees. At the NAACP, Donovan, he is our chair of the legal redress committee. So we're very excited to have him here. And he also holds a Master of Science in Educational Leadership from Winona State, and he's currently working on his PhD in Social and Community Services. So Donovan, thank you for being here. Rachel Schneider, she is a member of the NAACP. She's our treasurer, and she's also a nurse at Mayo Clinic for over 3 years. And she started her nursing career on the general medical floor. She currently works on the mother-baby postpartum unit. Is transitioned to the labor and delivery in March of 2021. And Rachel, she teaches and advocates for diversity, equity, and inclusion in Mayo Clinic through the roles of an instructor in the nurse residency program. In the summer, basically Rachel joined the Rochester NAACP, and has been very helpful for us. And so we're so glad to have you here. So with that, Donovan, Rachel, I will pass it on to you guys. But I will also be moderating our Slido section. So again, folks, encourage you to join in. Back to you guys.
Thank you, Wale. So I'd like to just give a brief overview of our events for today. So we are going to allow our panelists 5 minutes to introduce themselves and give opening statements. Then we're going to have 30 minutes of questions from Donovan and myself. These questions have been prepared for our moderators. And then, like Wale said, we'll go into 30 minutes of the Slido questions. At that same time, Barbara Jordan, who is off screen at the moment, will be moderating Facebook Live. So if you have any questions there, we'll be monitoring that as well. Donovan, do you have anything to add?
Just wanted to welcome everyone on this very balmy day in Minnesota. Great weather, good for a great discussion here today.
Awesome. All right, so let's get started with our introductions and our panelists. I'd like each of our panelists to introduce themselves. We'll start with Dr. Najero, then go to Dr. Warsame, then Dr. El-Rashidi, and then Dr. Maurice.
Thank you, Rachel. Can you hear me okay?
Yes.
All right, so my name is 𝐁𝐥𝐚𝐜, and I've had a long journey to Mayo. I was born in Kenya, and that's why I did my medical school. And then I came for training here for my residency and fellowship, and then I stayed on. So I work in community internal medicine. So I really one of the team members who takes care of local population patients, and I spend most of my days in the office really seeing patients. I also do some research related to how we can help to decrease health disparities amongst some of our most vulnerable patients. And that's something I'm very passionate about. So I'm excited to be here today and hope to answer questions. I know it's been a really tough year for all of us related to COVID, the COVID pandemic that has affected all the facets of our lives, so to speak. And we've seen the effects also in healthcare and how we take care of patients. But you know, having the vaccine has really been the light at the end of the tunnel. And I think we're really now seeing that more and more, and gives us a lot of hope. And so I'm glad to be here and if I can answer any questions, I'm looking forward to doing that. Thank you.
Thank you so much. Dr. Warsame?
Hello, can you hear me? Okay, great. So I'm Dr. Rama Warsame, and I am a hematologist, so I'm a blood cancer doctor. I've been in Minnesota now since 2010, and I grew up in Canada and did all my training here at Mayo Clinic. I feel so honored to be able to talk to our own community about the vaccine, about what has happened with COVID-19. I agree with Dr. Najero. It has been a very challenging and difficult year, but I also think it has been an incredibly eye-opening and hopefully opportunity to create momentum and make and affect real substantial change for our community. So I look forward to discussing this area.
Thank you. We'll go to Dr. El-Rashidi.
Good morning. Can you all hear me okay? Wonderful. Well, my name is Mohammed El-Rashidi. I too am a colleague of Dr. Giroux here in community internal medicine at Mayo Clinic. Born and raised in the Twin Cities. My parents are Egyptian immigrants, oldest of 3 and just recently married. I've been here since 2009 when I did my training. Jane and I were in the same class, and we were just a little bit ahead of Rama as well. And so it's great to be part of this, this community here. I am in community internal medicine as a practitioner, and then also I have some administrative roles as the section head for some of the internal medicine team members here in Southeast Minnesota, and then the community vision chair for the Upper Midwest. Really honored to be invited to be part of this. I think this is, as Dr. 𝐁𝐕𝐈𝐃 and Dr. 𝐕𝐈𝐃 pointed out, and as everyone's going to point out, it's been such a rough year, and the light is coming up at the end of the tunnel, and this vaccine and our efforts to try and combat COVID are hopefully coming to some fruition. So looking forward to the dialogue and the discussion today. Thank you.
Thank you. And last but not least, Dr. Maurice.
See here. Yeah, there we go. Can you see and hear me okay? Oh, good morning. My name is Bill Maurice. I'm the chair of laboratory medicine and pathology at Mayo Clinic. And also the president of Mayo Clinic Laboratories, which is essentially a global business that allows tests to come to Rochester from all over the world to get access to the labs here at Mayo Clinic. So because I'm in that role, I've actually been part of the national response. I was at the White House on March 3rd at the onset of the pandemic, and we have been very, a big part of the national testing and some global testing as well. In terms of background, though, which is probably more important, at least to me, and hopefully to you too, I'm originally from New York, and I grew up on Long Island. My parents got married at 19. My dad was a construction worker. I grew up in the city. And actually, when I was a kid, we used to host kids from the Black inner city community to get an experience to live outside. And so I think even though when you're young, you don't really understand everything, but you understood their background was very different. And that they didn't have the same opportunities that I did. And so then my parents decided to go to school because they were also hippies or hippie-ish. And so we moved to London and then to Indianapolis, actually, where we didn't have a lot of money because my parents had spent all their money on school. So I lived actually at the edge of a really poor white neighborhood that was bordered on a poor Black neighborhood and then an affluent white neighborhood. And so again, during my junior high in particular in high school, I really got to see the differences. I had a lot of friends that were from the Black community, honestly, I got to be sensitive to the experiences that they had and them not being good. And then I went to college at Indiana University, which is in Southern Indiana. Again, we had, unfortunately at that time, the Ku Klux Klan was still an active entity within Indiana, and the headquarters was in Martinsville, Indiana, which was in between Indianapolis and Bloomington, where IU is. And my Black friends would tell me how they would be afraid. There was one stoplight there, kind of like Canada Falls used to have between here and the cities, and how they would be afraid to stop for being harassed because a lot of the police were Klansmen there. So when I came to Minnesota, I actually it was very refreshing to me because I didn't feel that same racial division that I had seen growing up in Indiana. And I came here as a student in 1987, which makes me feel really old. Reagan was president, that lets you know how old I am. But, and I made my way up into a leadership position here. And it's been very gratifying for me. I did a PhD and an MD. I'm actually a hematopathologist, so I actually diagnosed the blood cancers that Dr. 𝐕𝐈𝐃 treats. But then the COVID pandemic really brought a lot of things that I wasn't sensitive to back to my attention. In the early days, in the first week when the pandemic was announced, I was emailed by a member of the tribal community here in Minnesota about just with a cry for help to get testing to their community. And we did what we could, but realized that the system really wasn't designed to serve those people as it was in others. Also had to think a lot about what was happening in the Black community in the Twin Cities as we were testifying to the state legislature for the state testing program. And then with all the events of George Floyd, it just brings to light that we have a lot to work on. And personally, I'm very committed to that. And Wale and I've talked about how we can use Mayo Clinic Labs in its position as one of the largest businesses in Minnesota to do that as well. So I'm really delighted to be here. I'm really honored to be here with all these other panelists. And hopefully we can answer any questions that you have and happy to take them. So thank you.
Thank you. All right, we'll get started with the questions. Donovan and I will alternate who's asking the questions. So the very first question we'll start with is, do you recommend getting the vaccine?
Jane, did you want?
You go.
Go ahead. Okay. So do you recommend getting the vaccine? The short answer is yes. I think it's important to frame this in terms of the context of what we're tackling here. Around the world, there have been 105 million cases. There have been over 2 million people who've died. In this country here, we have several millions of cases, 27 million cases, 450,000 people who've died. 60 million vaccines have been administered, but only 37 million have been administered. 37 million have been administered. And the scope of this pandemic has obviously hit our underrepresented communities, members of the Black community, the African-American community. Some statistics that just really are galling. You take a state like Louisiana, where in the Black and African-American community, they represent 34% of the cases, 39% of the deaths. Even though they're 32% of the population, they've only gotten 13% of the vaccine. Those numbers hold out whether you're looking at a state like Mississippi or Pennsylvania and across the country. We know that in the Black and African-American community, 1.4 times more likely to have cases in the African-American community as compared to the white community, 3.7 times more likely to be hospitalized, and 2.8 times more likely to have deaths. And so this disease has been tremendously impactful on so many dimensions of life, as we're going to highlight, and certainly in our Black and African-American community. So the short answer is absolutely, and for the reasons all just kind of outlined.
Yes, and besides what Dr. Al-Rashidi said, I'd like to add to that, COVID-19 vaccine is designed to help prevent us from getting infected or from getting very severe infection that will lead us to hospital or to get intubated or need mechanical ventilation. Besides that, it also will help prevent further transmission to other people around us, and will also guide towards achieving that herd immunity, so that we are so many of us in the community that are immune to the disease that it actually stops spreading. And the last thing that I would say regarding why we should get the COVID-19 vaccine is because when more of us are protected, it prevents the vaccine from spreading further and replicating further and changing and mutating. We've heard about these new variants that are coming from the UK or from South Africa. If we have less of the disease transmission, then we have less likelihood of the virus mutating. So many reasons for us all to get vaccinated. Thank you.
Thank you, everyone. I wanted to also say thank you to all the panelists. I haven't had a chance to say that. It's great to have you all out on a Saturday. I want to say a big thank you to Dr. Maurice. I am a Naptown native from Indianapolis, Indiana, a Hoosier. I'm more of a Boilermaker fan, but I'll use the word Hoosier. So, but thank you for coming. It's great to know someone is here from Indiana. Our next question is, there are several myths about the vaccines. They cause for infertility, they can change a person's DNA, and they can contain microchips. To name just a few, do any of these myths hold any truth?
I guess I'll kick that one off. That's also a simple one-word response. No, they don't. Unfortunately, there's a lot. I mean, that with social media and the interest the fact that COVID-19 is the global issue right now. There's just a lot floating around out there. There's always been some mistrust of vaccines. There's always been a lot of people that have these sorts of theories about vaccines. They're just not founded. And unfortunately, there are people out there that seem really credible. And I know that because even my wife, when I come home, has showed me these videos. Physicians and others that'll be on YouTube talking about this stuff. It's just not true. I think really go to trusted sources, whether it's, like a mayoclinic.org or something like that to get information, but don't trust social media. And that's honestly why I'm glad we're all here today, just to dispel those things, because it's scary and it seems legit, but it's not.
So anyone else?
Yeah, totally agree. I think one of the more concerning myths that gets out there is this is going to change your DNA because the nature of this vaccine is a little bit differently. So the way, and Dr. Maurice can chime in and others, and the way vaccines tend to work is we're introducing to the body something that when the body sees it will generate an immune response to protect yourself. And so every year, for example, with the flu shot, we're giving something that's part of the flu that's not going to cause you the flu, but that the body, when it sees the actual flu virus, it says, oh, this should not be in my body. Let me attack it. Let me prevent you from getting sick. With COVID, what the idea is that instead of giving a part of the COVID virus that can't get you sick, But the part of the virus that gets recognized, what's happening is this vaccine is giving you the blueprints. I kind of liken it to kind of the IKEA type of vaccine. It's giving you the blueprint and says, here, go build your own kind of target protein on this virus. And so then your body recognizes that, so that if you do come across COVID, it's going to recognize and generate a response. Now, people hear the talk about mRNA. Is this going to affect your DNA? Every cell is basically a bag of jelly. And in the middle of that cell is a vault. And that's the vault that has your DNA. And that's what makes you, you. The mRNA, that blueprint, gets put into the bag of jelly, never goes into the vault. When it's in that bag of jelly, what happens is the body reads that blueprint, says, what's this? Makes this protein, puts the protein out on the surface of the cell and says, has anybody seen anything like this? The body says, no, let's generate the immune response so that if we ever come across it, we're going to be protected. And then it gets rid of that blueprint, and then that's it. It never, ever enters the vault. It doesn't affect your DNA. It simply gives you that blueprint to create the protein to create your immune response. That's one way I've come to see to understand that.
How do we beat this at the ground level? And we may get to this question a little later. Certainly, you all are amazing professionals at the top of your professions. But as we think of the minority community, some of the impoverished communities, stereotypically, a lot of communities of color due to some of the conditions within America, how do we get what you said, Dr. El-Rashadi, at the ground level where it seems like it may be even harder to convince people that are skeptical of vaccines?
I think events like this of just trying to get out the information and to boil this down, because there's a lot of complex science. Dr. Maurice, Dr. Warsame, Dr. Giroux, and others can touch on that with greater expertise than me. But I think it's about events like this to just get out in front. I think there's the old adage about, a lie can travel all the way around the world before the truth gets out of bed to tie its shoelaces. So things like this are really important to try and get out ahead of misinformation.
Yeah,
true.
I would just add to that. Oh, sorry. Go ahead.
No, I was just going to say I really like that IKEA description. It really says it all. And I say, there's really no basis for these myths, but the way they're presented usually almost seems very convincing, with a lot of sort of sometimes scientific jargon and even references sometimes when you look at those videos, but they are not true. And so what the previous question about that Dr. Maurice answered and said, go to the sources that are real, go to the CDC website, go to the Mayo Clinic.org website to get the appropriate information. But besides that, I think at the personal level, spreading this kind of information through our networks, to our Facebook friends, to all the people that we know in social media, is also, word of mouth can also be very important in communities.
No, and I was just going to add in response to your question, Donovan, the other thing that I think is important, it's really not about our expertise. It's also about listening. So one of the things that I've had the real privilege is I'm actually working with the World Economic Forum to get COVID tools, particularly diagnostics, but then also treatments and vaccines to low and middle income countries. And I think really going in there with an ear to understand what people's concerns are, understand what they've heard. It's not just about science, right? This is very emotional. And so you have to really understand that first thing, it's not like I'm the science professional and here's why you need to listen. It's for me to listen to the concerns and then understand, because they're different in different communities.
Thank you. Rachel?
Thank you. So the next question is, do you recommend receiving one brand of the vaccine over the other? Can you individually choose which brand of vaccine you would like to receive?
So I would not recommend one over the other currently. Really, whatever vaccine is available, I believe is the best vaccine for you, because any immunity is better than no immunity. Currently, we have 2 emergency authorization availables with Pfizer or Moderna. Both of them use the same technology that Dr. El-Rashadi was talking about, where this blueprint goes into the jelly but doesn't go into the vault. But I think more importantly, if it will cause you delay because you're waiting for the other, that risk is so much higher than the current risk from either vaccine. And the benefits from these two are almost equivalent, 95 versus 94.5%, preventing you from getting hospitalized or dying from this disease. So I do not recommend one over the other. I recommend either. And if Johnson & Johnson or AstraZeneca come out and they get approved by the appropriate groups and reviewed, I would recommend those too, if that would mean that you would get it sooner, because I think the risk right now to our loved ones, to our communities, is the disease. And anything we can do to limit that is going to be key.
Thank you. Donovan?
Kind of going back to the previous question, but as it relates to the rapid access and production of the vaccine, it came in lightning speed compared to other vaccines that we've heard about. And the American public is just now getting to learn how vaccines are made and the timeframes. Obviously, these came rapid, quick, but in regards to that, it's caused a lack of trust around that. How would you explain to folks, okay, how this was able to come so rapidly as opposed to other vaccines to build trust?
Should I go first,
Go
Dr.
for it.
Marie? So this is a question I actually discussed with my family in depth, so I can tell you how to break it down. So first of all, yes, it happened very quickly, but this was built on decades of research. So if you all remember, I think I told you I'm Canadian, SARS in 2003, when I was in college, blew up, and COVID-19 is SARS-CoV-2. So because of that pandemic and the people who died, there have been literally over a decade of research on this coronavirus. So what they did really wasn't start new. They just pivoted to a cousin. So the work they did before really built this. Next, the spread of this disease was so much that they could finish a trial that normally takes 5 years. Also, everybody wanted to join this trial because everybody wanted to do something to make this go away. So not only did they get the participants to the study, there was so much disease that you could find out if it was working very quickly, and it was built on a decade's worth of vaccine research. So I don't think it's even that fast. The things that were faster that we may want to review is the regulatory paperwork, that we may want to shave off a little bit of that in the future, but that's it. It was just the paperwork that was faster. Everything else was done exceptionally well.
Yeah, no, I agree completely with Dr. Warsame. I really like Dr. El-Rashidi's thing about the bag of jelly and the vol. It's a great analogy, but it also made me want a donut, which is I'm just gonna put that out there. But no, I agree. There's a couple other things just to keep in mind. Actually, first of all, what we think about drugs getting approved in that process, that actually started in the 60s, right? So that with the thalidomide, I'm old enough to remember have kids in my school that had limb that were shortened from thalidomide because there was no FDA process to approve drugs. So that's, you're talking about, now a 60-year-old system, right? That probably needs to be reformed. And so that's number one. Number two is actually, I was on a different panel with Dr. von Eschenbach, I think who was the FDA commissioner under George Bush in 2006 to 2009. And that's where actually the technology used for the Moderna and Pfizer vaccines, which are the newest and causing people a lot of consternation, a lot of rumors, actually started then because of the avian flu. So those remember there was concern about the avian flu and that we couldn't, the way that we made vaccines was just too slow to respond. So this technology has actually been worked on for over a decade and has actually been used in trials for Ebola. I think there were some and also a couple others. So it feels new because we haven't heard about it, but it actually is something that we have been working on for a long time. And the last thing I would just say is that from my position, I've been able to see that a lot of the speed that we have is teamwork between the healthcare, the pharmaceutical industry, and the regulators, both in the U.S. and globally, recognizing, to Dr. Warsame's point, that this is a problem that needs a very quick solution and needs some flexibility of thought. So I trust it completely. There are things that we don't know. We'll be honest. We don't have the long term. When people ask about what are the long term effects, we don't know because they're new. We don't suspect that there's going to be anything, but we can't say with absolute certainty. But we can definitely trust the science to say that in the trials, they didn't cut any corners. They just were able to do it extremely quickly because they looked and just because of the interest and the teamwork across the globe, essentially.
Dr. Warsame, you said something about if you had a concern about the speed, it'd be the regulatory paperwork. Can you explain that a little bit?
No, so what I mean, if you have any worries about how this happened quickly, it wasn't the science, it wasn't the study, it was the fact that we were all working together and getting rid of bureaucracy that hasn't been necessary, that hopefully in the future, we will eliminate some of the paperwork that is repetitive. What we did is really streamline, and sometimes desperation just forces you to have invention, and they have become more efficient. Groups are working together. There's no more little silos. You go to this paperwork. It's like when you file your insurance and then you're like, okay, the prior auth. They have streamlined it. So if anything, I think that hopefully this has made all approvals more efficient so that we can get science to the people at the appropriate times with the same degree of high safety. So that's where, if any of the speed came, was the fact that we finally started focusing on the inefficiencies of our system.
Yeah, I would just add, Donovan, that one great, so I agree again completely. This is going to continue to be with us, right? Because we know the virus is changing, and so we're going to have to continue to look at how we produce vaccines. And so the regulatory science is how we call it. Will have to continue to evolve. For people who are interested, one source that I really like on Twitter, I'm on Twitter too, is actually Dr. Scott Gottlieb, the former FDA commissioner. He and now is in the pharmaceutical industry on the Pfizer board. He talks a lot about this in a very understandable way. So that's that. If you're thinking about a trusted source, if you have questions, he's a good one.
I just wanted to add one last.
Necessity is the mother of invention, and certainly we've seen that in this past time. One more quick question as it relates to trust, and we'll get into some other questions as well. And this is no diss, if you will, to your professions as it is stellar, right? But it seems like there's a portion of this that is, hey, we don't know everything, but this will do. Just go for it. 80%, 90%. There are things that we don't know. We're just, hey, just do it. We'll worry about the rest later. And I know that makes sense, but I think sometimes when we listen to the news, social media, whatever, when we hear that, oh, there's an unknown about babies, or there's an unknown about pregnant moms, or there's an unknown about this, or there's 90%, 80% of this vaccine versus that vaccine. How do you deal with that trust factor? Because I think that's probably part of, wait a minute, they rush this thing, and every now and then you hear the disclaimer, we don't know. I'm sure that scares people as well.
So maybe I'll fall on this one here because it's a big question, and it's the real question of how do you build trust. And I think there's a part of the discussion here is we have a bad history in healthcare and in medicine with building trust with the Black and African American communities, with underserved communities. We have a lot to own up to and to overcome. So let's put that out front and center. The nature of science is dealing with unknowns and dealing with probabilities and what's more likely and less likely, and learning more. What do we know? We know that this pandemic kills, period. We know that this pandemic can be very severe. We know that this pandemic can easily spread to other people, this disease, coronavirus. We know that people in the Black and African American communities, Hispanic, Latino communities, other underrepresented communities are dealing with this at a harsher, experience than others. Those are facts. We know that the healthcare system has disparities inherently. That's a fact, and that this pandemic has shown. What the science has shown, I think that's another question Dr. Maurice and Dr. Warsame or Dr. Drew can highlight. The studies that were built to look at these vaccines are very rigorous and did include members from communities of color to show the safety, to show that it works. So something that's 95% effective at preventing this is huge. And to the last point about the rush, imagine if 40 years ago, the world and all these health institutions came together quickly to say, there's a virus that's spreading in the community that's killing people called HIV/AIDS. We might have knocked out HIV/AIDS 30, right, 40 years ago with this rush or other viruses. So just to those points.
Amazing. Thank you.
Sorry, go ahead, Jane.
In addition to what Dr. Rashidi said, I think it's important to keep in perspective the fact that I'm not actually aware of any vaccine that, say, we give to people and we tell them it's 100%. I'm not aware of any unless somebody in the panel is. In fact, getting 94%, 95% is really, really good. Sometimes the seasonal flu vaccine that we all get is, 60% is, and it's because of the nature of the virus and how quickly it has to be produced. And, sometimes there's a little bit of the thinking about the most probable type of virus that will be there. So what the main point that I wanted to say, it's important that we are transparent and say, the exact percentages that there are. And when we're uncertain, say that we're uncertain because we don't know. But it's the 95%, 94% are really, really good within the whole perspective of vaccines.
Jane, I completely agree. What I was going to say is I take care of maybe the most afraid patients. So my patients are inherently immune compromised because of the blood cancer. I then give them drugs that are essentially poisons to kill those cells that protect them from viruses and infections. So now you've got someone who's immune suppressed from disease and treatment. Okay, so these patients are very frightened. And I talk to them that the treatments I give them right now to try to keep them alive, if they had the efficacy of this vaccine, I would be overjoyed because more of my patients would be alive. And even though they didn't test it in my patients' population, severely immune compromised, the risk to them is huge. If they get COVID and you have a heme malignancy, the risk of death is so high. And if you're willing to take poison to live, I strongly encourage you right now to take a vaccine that is more effective than the chemo I give you. And when we talk about it like that, it really helps understand kind of how you weigh these unknown risks and benefits of every decision we make.
Great perspective. Thank you.
Yeah, I just had to jump in there, Dr. Wasami. That was very crystal clear, and in terms of the risk versus the reward and benefit.
I'm loving this discussion. The next question is, how do you know the vaccine is safe? And we've gotten into this a little bit, but if our panelists could dive a little bit more into how do we know this vaccine is safe?
Dr. Maurice, go forward.
Okay, sure.
Yeah, please,
Well,
no, please.
You have to really look at, I mean, there you do have to look at the science, right? So for the vaccines that are out, so just so you know, for every vaccine and for every therapy, so there is actually what's called a DMSC, a Data Monitoring and Safety Board, which is independent, right? Which actually looks at what's happening, looks at the information for patients that are in the trials to see if there's anything, and they have the ability to stop it if they think there's something that's harming patients or individuals that are in the trial. And I know that because actually I was a part of that for the convalescent plasma program for a time. I actually had to step away because I was so busy, and it's an important job. You have to spend a lot of time to. So we had this for both of the vaccines. They had a lot of people, and they did work hard. Again, going back to establishing trust, we know that in the past, many of these trials have not had good representation of minorities, right? So to get the trust for all communities that the drug, or in this case, the vaccine, was safe. These did have good representation, both for Pfizer and Moderna. They had tens of thousands of patients in them. They had careful review, and that data had to be reviewed by this independent board and the FDA to get the emergency use authorization. So there's a lot of good science here. And again, we have to be really careful, because what happens is now millions of people are getting it. Tens of thousands is a lot, but now millions are. And some people are going to get a vaccine and they have other health issues. In fact, particularly when we're trying to help, as Dr. Wasami was saying, vaccinating people that are really at risk. So there's going to be people who get vaccinated and then have something bad happen, because bad things happen to people, unfortunately. So, but the science around the studies themselves is really rock solid, and that's what I look to say that these are safe when someone asks me, including my family members.
I completely agree, and would only add, so there's the adage about do as I say, not as I do. So we all know that growing up, we've all heard that phrase. Proof's in the pudding. I think for all of us here in healthcare and in medicine, as close as we are, we're not, maybe with Dr. Maurice and Dr. Wasami, especially with their with chemotherapy regimens and with Dr. Maurice's expertise, know the science really front up. But for all of us in healthcare, doctors, practitioners, nurses, you'd be one thing if we told people to get vaccinated and then we didn't, because you'd say, oh, we know something that others were not sharing. if you look at the numbers, and I can cite to at least the institution we belong to here, those numbers are 80, 90% plus and growing. So we're all stepping up to say, when we're eligible, yes, we want the vaccine. And so that is a consistency of we're saying and we're doing. If that hopefully adds more trust as well, we would not want something that would endanger all of us in the community, of course, our families or ourselves. So we're doing the vaccine too.
Yeah, I agree. And the only thing I would add then is just to remember, there's what you feel and there's what you know. Look, even when I got my vaccine and I did, it was a little, I'm not gonna lie, I was like a little, wow, what's going to happen here? After I got I went and looked in the mirror, my face blowing up. I mean, you just can't help it. I mean, that I knew in my mind that it was fine. But it's the unknown, and the unknown is always going to be a little bit intimidating. But you can't let people take advantage of that to keep you from getting something that's really going to help not just you, but also the people that Dr. Warsame was speaking to, right? Because vaccines have two purposes. One is to protect people from getting sick, but the other, as other panels have said, is to prevent the disease from spreading. And there's some people that won't be eligible to get the vaccines. Certainly, it's just difficult getting the vaccine distributed to everybody. But the more who get it, the more less likely the disease is to spread. So just don't let people take advantage of those emotions. Really, use your head and your heart.
Thank you. Donovan?
All right, when folks want to get a COVID-19 test, what would you suggest, the PCR, nasal swab, or the rapid test?
So again, a test question. So I guess I'll start there. You start this one. So with the COVID tests, for the virus itself. So we're talking about testing for the virus. The blood test tests if you've been exposed to the virus and mounted an immune response, the so-called serology test. But the testing, do I have the virus? There's really two, there's different specimen types, and then there's different types of tests. So what we really want is the specimen type that has the highest likelihood of having virus in it, and the test that has the highest likelihood of detecting it, particularly in people who are asymptomatic. I mean, one of the real challenges with this pandemic, unlike SARS, the first SARS, which Dr. Warsame spoke to, the first SARS, people spread it when they were sick. So it was easy to identify who had it and keep them from spreading it to others. This one the real challenge with it is that people spread it when they don't know they have it. So we need a test that you don't know you have the virus, but it can tell you so that you can keep yourself and others safe. So really the best right now that we know of are in terms of the specimen type, are something that goes in the nose, further into the nose. Then there's a nasal pharyngeal swab, which goes way back. Some people call it the brain biopsy. It's uncomfortable. Mayo has developed one which goes not as far back, but still goes into the nose, called a mid-turbinate swab. That's a good one. The ones that don't seem to work as well are the ones that go just in, just like a Q-tip in the very nostril. Those, there's just not much virus there, right? And then the saliva is good. That's the one that the state offers, the vault test. But it's actually not just spitting. There's actually a collection process, and it takes a little while. So you have to really follow that, and you have to have a video call that someone helps you. And then the best is still the in-lab PCR. There are rapid tests that we are developing, and they're being developed that are as good or nearly as good. But so the best really is probably a nasal specimen with an in-lab PCR. But there are other good alternatives, but really, again, understanding, and that's actually one of the concerns, particularly as we look at for the low and middle income countries, getting antigen tests and, things that would be on a card that you could kind of do like a home pregnancy test. There, of course, there's a real interest in that. The challenge is that some of those are either they're not as accurate, and then people are reticent to take them because we have to understand what happens with a positive result. For even in our country, in our communities, a positive result might mean that you don't get to go to work, and you might not be paid for that, right? So we have to keep that in mind. If it's something that's that critical for you and your livelihood, then we really need to make sure you have access to the best possible test.
What about the antibody test? Just recently, Hy-Vee locally here in Rochester was doing a $25 antibody test for those that wanted to know if they had the disease. And myself, I was about to go down and get one, pay my $25, let them take my blood. And then I thought, well, I don't know if I want to be giving my blood to the place where I get my milk and cheese. So I decided not to do that. But is an antibody test good just for the whole process?
Well, early on, there was unfortunately a lot of really poor quality crappy, to be honest, antibody tests that were put out there that really undermine people's trust in them, right? And it just speaks to like today, the hard thing with trust is it's so fragile, right? It's so difficult to create and so easy to break. And so a lot of people just said, well, I'm not going to get them because they're bad. We actually did a story with ABC just to highlight what was good versus a bad antibody test. The challenge right now is you don't really know what to do with that result. You know, when you go get it, it says that you had it. What we'll see, Donovan, and what's being worked on is actually some kind of like immunity passport. It's something that we'll probably see down the road, so that, you know, when you go to the airport, it's just like having your safety code, or to go to an event, you might have to have something on your phone. That's when we might see some of these antibody tests kind of come forward. So right now, if you're curious, if you think I might have been exposed, it is a good test. The ones that are out there now, like at Hy-Vee, are high quality tests. But remember too, though, if you have the antibodies, that means you did have SARS-CoV-2 infection. Even if you didn't know it, you might have been asymptomatic, but you still need to get vaccinated. And I think there's questions later about that. So it doesn't mean that you can just say, oh, I'm safe, I have the antibodies. You have to still, you know, talk to a provider, and you should still get vaccinated. So
it is somewhat good. And from what you're saying, it might be maybe a requirement down the road to make sure that folks know what's going on as you go through to get on the plane, to buy your cheeseburger, to buy your car. Joking, but it sounds like that's going to be a bigger piece of the maintenance of this issue going forward.
it could be, and hopefully cheeseburgers won't be that hard to get in the future, because that would really be tragic for me.
Thank you.
Thank you. The next question is aimed more at trust as well. So it is, what happens with the swabs, nasal swabs, or just tests in the lab? And how long does it take to get COVID test results back?
Wow, so a lot of test questions. So that's fine. So what happens actually is you have to do two things with the nasal swab. It's actually the media, so the liquid that the swab goes into is what we test. And so what we need to do is actually extract the virus out of that material, out of that liquid, and then we run a very specific test. It's essentially looking for those blueprints that Dr. El-Rashidi spoke to, right, in the specimen. So that's what we do in the laboratory. That test is over 99% accurate. So if you get a positive result, that means you really do have the virus. We now can get those what we call turned around, so get a patient result typically in less than 24 hours. For that test, it's, I think, down to about 18 hours. What happens after? We do freeze some of those specimens and hang on to them, the positive ones, just to be, in case the patients want to get for whatever reason, the doctor wants to retest. Sometimes they don't believe the result, or there might have been a problem with the run or something else. Because these are all going through these massive automated machines. That's the only way we could do the tens of thousands of tests a day that we were doing. And then there are times that we want to go back and look at those, particularly now with the concern around variants. In fact, we're working now with some of the sports leagues that are having trouble with COVID to say, are these some of the newer variants that are easier for people to catch? There might be times that we go back and look at those specimens, but they're always de-identified. There's not something that's happening, and honestly, we then end up discarding them eventually.
Thank you. Donovan?
All right, this is probably one of the bigger questions, I think, on the ground practically. For those that have got the COVID-19 virus and have that natural immunity, do they then need to get a vaccine? It seems as though that's really impacting behavior. Oh, I've had it. Or those that just say, whatever, I don't need to get the vaccine because I've been exposed. Is that true? And how should that change?
So I guess I'll start here, and then I'll leave it to my other panelists because I don't want to be dominating the conversation. But interestingly, my PhD is actually in immunology, so I know a little bit about this. So there's two pieces of information I would say. Actually, interestingly, in the United Kingdom, they went back and looked at their healthcare workers who had gotten COVID. And the long and the short of it is that it does appear that most people who get COVID get immunity from that. The rate of reinfection, and we know that, look, millions of people have gotten it, and the rate of reinfection is low. That being said, as Dr. El-Rashidi said, the advantage of the vaccine is you're actually giving a known dose of the thing that stimulates your immune system to create a protective response. So that's why you should really get it. You can think of it as essentially a booster. If you've had infection, you can boost your immune system to really get a higher level of immunity. And we just don't know. Honestly, some people, particularly if they're asymptomatic, there is some evidence to suggest that maybe they didn't get a real strong inoculum or real strong dose of the real virus, so they need a boost from the vaccine. And I'll let my other colleagues weigh in.
Yeah, I'll jump in. Definitely agree. And with the concern with the variants, and so the vaccine is still deemed to be effective. And correct me if I'm wrong, Dr. 𝐁𝐕𝐈𝐃, it's 90, and Dr. Everyone, 90 days, I think, is what the guidance is to say if you've had an infection, wait the 3 months, then you should get the vaccination, because that natural immunity period is not known how long it is or how specific. And as Dr. Maurice highlighted, you might not have had a strong enough dose to get that boost of immunity long term.
In regards to that, do we know, or at least are there studies that say how long natural immunity lasts, and then 2, how long the vaccine will last?
No, I mean, the reality is we're still learning, right? I mean, this is still new. It's funny. I go through my email inbox and I look at ones from January 2020. I'm like, man, I had no idea what was coming, right? It feels like it's been here forever, but we're still just coming up on a year, right? So we still have more to learn. The evidence suggests, if you look at the first SARS virus, people got years long immunity from that. And there was another one called MERS, which was in the Middle East, which was, we don't talk about as much, but also in the same family of infections that also had durable immunity. So we're hopeful there'll be durable immunity. But we know it's funny. I've been thinking about this morning because I've been on sports radio a lot talking about this, and I wonder why sports radio. Well, because nature is competition, just like we have in life, right? And there's this competition between the virus and us in terms of the virus trying to stay ahead, and that's where these variants are coming from. So that's why we'll have to continue to think about how we, change the vaccines and keep track. That's why people get reinfected with other viruses as well. So we're going to have to continue, but right now we just don't know the answer. But our best guess is that you're going to have some at least a year long from what we know already, but probably longer.
Thank you.
All right, next question is, what can you do to help yourself stay healthy while waiting for your COVID vaccine?
So I can take that one, and then maybe Jane, you can jump in. I think it's pretty clear what we can do. It's not easy though, because it's been a long year, I would say. So it's washing our hands, it's wearing our masks consistently, even after we're vaccinated. It is social distancing. It is avoiding, honestly, almost all unnecessary social gatherings of any sort, keeping your bubbles as small as you can, while recognizing that we still need to maintain our mental health, our physical health, and our emotional support systems. And we need to work and have a livelihood so that we can live. So with that in mind, trying to keep that bubble as small as possible. Each person, it's individual, but if we could all just wash our hands and wear our masks consistently, I think that alone will make a tremendous, tremendous benefit. And then we can all hug again and love again. I'm a hugger. My patients know this has been very difficult. So I think that we will get there, but if we can do the work now, I think we're going to have the dividends later.
Yeah, I don't think I have very much to add from what Dr. Warsme said, but it's tough being away from people that we love. We're human and we all want that social connectedness. But taking advantage of such tools like the one we're using today to talk to people, to see their faces, I think we should do that as much as possible. But keeping in mind, sometimes those small family gatherings where we join 2 different bubbles together or 3 different bubbles together, sometimes are the highest risk ones. So, masks, hand washing, physical distancing, all of those.
Thank you. Donovan?
We've had a lot of questions about trust, and this is along the same lines. Obviously, the Black community has some fear around this vaccine due to the Tuskegee experiments. I'm sure the Native American community and other communities as well. I'm not going to take this vaccine. I want to twist this just a little bit as we've been talking about trust. I think one of the things I'm hearing and feeling is, oh yeah, okay, they got the vaccine. It was super rapid. And I'm just going to keep it real if I can. They did it on a bunch of white people, right? And so it works for them. But if I take it, I'm gonna grow 2 left arms and 3 feet, right? And that's kind of being, I'm exaggerating there. But I think part of that fear is maybe it's not gonna kill me, but the fact that they tested, 99% of white people and it worked for them. But if it comes to the Black community, Native American, Latinx community, it's going to make us die because of our proclivities for whatever our DNA has. And I'm kind of exaggerating, as I said, but I think that's part of like, okay, yeah, they did it for the white people. And again, I'm being facetious here, but it really doesn't work for Black folks and Latinos and what have you.
I'll jump in on this because I think, like you said, Donovan, kind of keeping it real here, and that's a perception that's out there. We have to own it, and it's not just Tuskegee, right? It's a history of failings. It's Marion Sims, right? It's Henrietta Lacks. It's countless instances and the disparities that exist just here today, not just historically today. That the healthcare system, our society, racism is embedded. We've got to be anti-racist, and that's stem to stern. And forums like this, again, trying to dispel misinformation. So talked about the studies, and maybe Dr. Maurice especially can highlight this, but either Dr. Giroux or Dr. Warsame. And the Pfizer study, they studied it on 43,000 people. Of the 43,000, 17,000 were of communities of color. So that's a huge chunk. Of the Moderna vaccine, it was around 30,000 that they studied in, and it was 11,000 in communities of color. So the data is there, and I think as Dr. Giroux maybe can speak to about the real focus that institutions nowadays have to have on human protection, but also ensuring that studies that are being undertaken have a very clear focus on involving and engaging communities of color, underrepresented communities, because of the point that you just made. So yes, there's a history we don't want to just whitewash or ignore. Yes, there's a real-time disparities that exist. The science and the efforts right here and now show that this is safe. And I shared the thing that Dr. Maurice was highlighting, get the vaccine, you're like, what's going to happen? And you're worried. And I think it'll be important for us to talk about what to experience, because yeah, it's a vaccine. You have an immune response that's expected, that's appropriate, and short-lived, because the alternative of getting COVID, we know, is disastrous. So I'll stop talking, but I just wanted to highlight those points.
I would just add, we have to acknowledge what has happened before. And, with that, the Tuskegee study going on for so many years, from the 1930s to the 1970s, is painful. But I'd say too, that after that, there has been, some real effort to try to prevent something like that from happening again. And I've had the privilege of sitting on some of these boards that review studies, even here at the clinic. So-called institutional review boards that review any studies. And really the focus is to make sure that there is, in any study, that it is safe first, but that there is respect for people, so respect for the persons, that there is benefits, and so it's going to do good for the people who are taking part in that study or whatever it is, and then there is justice. So those are really key principles, and we comb through documents like with a fine-tooth comb to just make sure, with special instructions usually, that we pay attention to people who are more vulnerable, and that includes people who've traditionally been subjected to significant injustices through research. So I think that is, in a way, is reassuring for me, but at the same time, I fully understand the hesitancy of people to even take part in studies, or to trust, to just trust easily. And I'm really glad that we're having this conversation and being able to bring these things out and discuss them.
I just think that's the $1 million question, right? Like, we have done harm. The reason COVID is killing Black people right now and Indigenous people is because of the harm that we've done that is consistently affecting us. So your fears, I feel like half the problem is 100% real. You should be very judicious. You should always go in with some amount of skepticism at minimum. But the irony, so I'm a cancer doctor, the irony now that is so painful to me as a Black person is that the trials now are the access. They're the keys to get into treatments that let you live longer, live better, and have opportunity. And now, because of the trauma we did before, and I say we as in the medical community, our poor Black and Indigenous people are not joining. And now it's the complete opposite. Patients of mine who go on trial live longer, even if the drug ends, even if the drug doesn't work, they live longer. You want to know why? Because they watch them like a hawk. They support you. You have a nurse, you have a data safety board, you have the industry, you have the PI, you have your doctor. There are so many people watching you, keeping people in check. You're better off than the you and your doctor just alone because of the scrutiny, because of the trauma. So it is so painful to me to think that we don't involve in trials, because now it's the way to get therapy, to get opportunity, and to be supported and treated better. So if I could get that to the people, it is so important to me that people know that, because we're not living longer because we don't join trials. And I tried to join this vaccine trial in every country. Like, I applied for UK, I applied in the United States. I coveted this vaccine. I don't think I've ever coveted anything. Like, I now know what that means, because this vaccine will dramatically improve our lives. And I accept the risks, because there are things we don't know, but I don't know what's going to happen when I get in my car in the morning. And I'm okay with that.
You know, I think that, look, it is $1 million question. And the answer is not, it's not a piece of paper. You know, it's not just a study. Trust, and it's not even me. I mean, I have to go through, all of us as doctors have to go through the IRB and acknowledge it's a Tuskegee study, but that's not enough. You know, a trust is built through dialogue. Trust is built through understanding, and then real dialogue. You know, even in my own family, there's about, well, we texted back and forth and we've had a conversation. I'm like, that's not a conversation. All right. Conversation is this. That's why I'm so appreciative to be here. Conversation is me understanding why you guys are afraid, and then internalizing that and making sure that I address it. So, and in a way that's meaningful for all of us. So I think it's things like this, honestly. It's more interaction, it's more dialogue, it's more acceptance, it's more recognition. It's more continually looking in the mirror and saying, how can I do this better? And that's for all of us. So yeah, I think that's the big part of it. It takes work, but honestly, and it's worse now because of all the disconnection. But the secret is, beyond COVID, I mean, I worry a lot about the psychosocial and the psychological ramifications, and let's use this to build our community. I mean, a community, right? Not communities, but let's still use this to build a community. So that to me, that's the thing, and that's what I can do. And so thank you for having me here today.
As a follow-up, and this is kind of a political question, and Dr. El-Rashadi will love this, as we serve on the Equal Justice Committee together and we kind of ruminate about these things. But as it relates to the vaccine in the minority community, and I heard this about California, apparently they've set up vaccination distribution centers that are adjacent to minority or impoverished communities. As it relates to and I know we don't have a lot of vaccine comparatively right now, it's coming, but as it relates to the tier of who gets the vaccine, and I know this is a tough question, as we know that the elderly are disproportionately impacted by COVID-19, obvious. They should get it on that top tier, if you will. But as we've been saying, the minority community as well is disproportionately impacted. Should they, again, political, have minorities at the top tier, if you will, not only to deal with the issue of them getting COVID-19 more, but also to show a trust that, hey, we understand we've screwed up, or at least the health system has historically screwed up. We're going to even come here first or second or third to show you that this is real and we can make a difference.
I think that's a profound question, and I think from the standpoint of, first of all, if we had a magic wand and could give everybody the vaccine, we would, and do it now. And I think, as Dr. Warsame highlighted, coveting this vaccine, I think for all of us, especially in healthcare, and seeing the stories, and Dr. Maurice is from New York, and I'm sure looking at back his home state, and the experience at the front end, the trauma of just seeing people succumb to this illness, and to Dr. Warsame and her patients, and Dr. Giroux and the community and her patients, and all of us. and I think I thought I saw some questions about what about patients with diabetes or other patients with high risk, Dr. Warsami's, cancer malignancy, the blood cancer patients. I think it's a profound question. I don't know the right way to do that, because I think you're highlighting something interesting, which is that there are so many disparities that exist in healthcare and communities of color, the Black African American community, especially that's suffered, as Rama said, because of harm and neglect. If prioritize at the front end, say we want the Black and African American community right up at the top, because we're trying to show, as you're talking about, to try and make amends. If messaging like this was profound and folks would rush to it at the level we see among doctors, 90%, great. I think what we're seeing here with the disparities is both the hesitancy. I think Dr. Warsami pointed out there's this tragedy of people are already hesitant because of the trauma and the history. And if we put this front and center and say we want Black and African American communities and indigenous populations to take this first, would that double back? Would people say, well, hang on, this is all new. We're already trying to deal with misinformation. Why are you putting it on us? So it's this, and I don't know what the other panelists would think. It's this really, you've asked a very profound catch-22 question. So there are family members that we want to have vaccinated. There are loved ones we want vaccinated, our patients, our communities, all of us. We wish there was enough vaccine that everybody could get it right now, tomorrow, today, if they wanted. And frankly, we would love everybody to do it. I don't know about that policy question. I can say, and I'll end with this. I sit on the American College of Physicians Minnesota chapter in the Policy Council, and we talked about this. The statewide distribution as they're targeting, especially the elderly population. I think across the board, the 65 and older crowd, the 80 and older crowd, nursing home populations. That was one pass. But at the same time, when they did the statewide sign up, who's getting them? And as we talked about the states, predominantly, white populations are getting this. So it's a profound question. I don't know the answer of how best to tackle it, other than dispelling misinformation, encouraging others to get it, saying this is safe, and really, taking strategies to broaden access points for the vaccine in communities that have historically been underserved and wronged, frankly.
Yeah, that's very eloquently said. Just a couple personal experiences that tried that home for me that were very eye-opening. One was actually well before the pandemic. So I mentioned that Mayo Clinic Labs is global. So we were in a South American country where we were setting up testing, and they were very excited. So they had a press event. And just before I went on, it was a woman who was a very good reporter. I've been on CNN. Just before I went on, she turned to me and said, "So is this all about Mayo Clinic coming down and price gouging our community?" And to realize that was a perception, right? I was just like, here I've grown up. I came here when I was 21. I always thought, Mayo nonprofit, needs of the patient, and to have that perception out there was like a bucket of cold water in the face. Also, in the early days of bringing it closer to home, in the Northern Hemisphere, in our state. So in the early days, look, there were just not enough tests, right? So you had a situation where a disease that didn't exist, all of a sudden, every single American needed a test, right? And there just weren't enough of them. So what happened was the White House worked with a few entities. Mayo Clinic was one, Mayo Clinic Labs, to say, okay, you guys, we're going to give you the resources. You help us get the testing out there, because there's just not enough. So I was at the state legislature kind of talking about this was the state plan. And again, and the hospitals in Twin Cities just couldn't get them, because they just couldn't. The White House was deciding where it went. So I was there saying, we have it, can we help? And so that someone said, one of the other healthcare systems, well, Mayo Clinic is just about headlines. They wouldn't be here if they weren't going to get a headline. And again, it was just like, man, it was like, it's not true, at least for me personally, but it made me think, we got a lot of work to do. We got a lot of work to do because if that's a perception, someone's perception of you is their reality, right? So to really understand that becomes critically important. Because same exact concerns is that as soon as I heard that, I thought if we try and put this out, as Dr. El-Rashidi said, if we try and get this out to those communities that really need it, that would probably be the first response is, okay, yeah, you want us to be the guinea pigs, essentially.
I wonder, though, I think there is opportunity here, though. It's clearly disproportionately going to other communities right now. Even among the appropriate ages, there's a horrible incident that happened in Yellowknife, which is in Canada, where a 55-year-old CEO flew out to an Indigenous population and said he worked there and got the vaccine for him and his wife. And it was currently going to literally people who live so far remotely that they had to fly it out there and build the fridges and everything to try to get to this very low access community. So there is clearly disproportion. So I think the key though is transparency. We need to know who's getting it. Then we can readjust on a constant basis. Right now, it's like, who? And this only adds to suspicion and concern. And I just think transparency and reporting, just like reporting of who gets the tests, who gets the disease, we need to have it like on a national dashboard. We should all know California County, Olmsted County, who's gotten it. And I think then there's a sense of like accountability that happens when you're open and honest. And that's what I would argue for policy wise, rather than trying to necessarily pick exactly who should get it. We establish what should be happening, and then we have open accountability for what is happening.
That is fabulous. Politicians, hopefully you heard that. Wale.
And I was just going to add one quick thing too, from the point of view of structural barriers. One of the things that has come up is related to, will I get it if I don't have health insurance, for example, but just making sure that is communicated really clearly. Will I get it if I don't have a primary care provider somewhere? Making sure that we have pathways that decrease each of those potential barriers. We think about them and get them all set. And that's part of listening and understanding what barriers people are facing, those who want to get the vaccine.
Yep. So speaking about transparency, so we're gonna segment to our Slido audience participation segment, and we'll just so audience members, any questions you guys want to share, please go to slido.com and put in the NAACP Rochester MN. And so any of our honored guests, please feel free to answer this, but I'll say the first question. And again, yes, we've answered some of this, but we need to hear it multiple times. So please explain how the vaccine is safe. I am a little unsure with all the different information I'm hearing. And maybe we can also talk about just the whole process of the trials, how that goes about. So whoever wants to take that.
Sure, I'll take the first crack at it. So, again, there are tens of thousands of individuals in both of these trials. And the way the trials work is there are cohorts, that meaning there's groups. There's one group that gets a vaccine and there's the other gets a placebo. So something that's a shot, but it's not the actual vaccine. And they watch, right? And they watch and see what happens in these groups. They watch to see how many people got COVID in each group. And that's where they got the 99% efficacy, because there were, if there were 100, that meant if there were 100 cases of COVID, 99 of them were in the people that got the shot that wasn't the vaccine, and only one was. But then again, they watching continuously to say, what's happening to these people? Are they having any kind of health problems? If there's a health problem that looks like it might be more in the group that got the vaccine, they have the opportunity to stop the trial. And we saw that with one, AstraZeneca, that actually got stopped, right? Because there was an event in one of the vaccinated individuals that they were concerned about. So that's what's out there, and that information is back. And they're also, look, they're not totally benign. They have to get your immune system revved up. And so some people, about a third of people, will feel pretty sick with it. I got kind of achy. I got my second shot. I got the aches, like I felt like I was getting the flu, and it went away. But that's, the data is real, and the information is real, and just go out there and look at it. And again, the most important thing is to look at a trusted source, because that's where we start to feel unsafe, is when we start to hear all these urban legends around the vaccines.
Okay, no, appreciate that. Second question is, again, trust. I mean, this is a question about, we're talking about COVID, but underlying is really about the trust factor. Black folks have been used for experiments like Tuskegee and others in the past. How can we trust the information that the vaccine is safe? Anything else anybody wants to add to the conversation we've already had?
Wale, I just want to add, we're getting some audience requests that we really hear from Dr. Najero and Dr. Warsame.
No, great. So not Dr. Najero, Warsame.
Dr. Najero, do you want to go first?
You can go first.
Okay, I'm a personally skeptical person. Like I'm going to I completely understand and respect I said that earlier. But I think the reason I feel more comfortable, most of my cancer trials, we're talking 99% white males. We're talking like absurd numbers, 96%, 95% white, and then like majority males. This is the first trial I've seen that had intentionality built in. They had sites in the areas of low income, indigenous people, people of color, color communities. People were involved in the trial at the like development stage, included perspectives from our communities. And I feel like this is the most inspiring I've ever been in my lifetime of medicine, really working together and recognizing. And I think it helped that the social unrest that happened last year after the tragedy of George Floyd was right before phase 3 trials opened for all of these. And I think, I don't know what changed, but the proportions of people that include us, so that we know at least that what it would happen if it were to be given to us, I felt much more assured in that regard. And also there's continued monitoring. I think people think the trial has ended. People are still monitoring the people who were in the trials, and there's actually a national registry for everyone who gets vaccinated to report anything that happens so we can build more data. So I think safety data is coming, but this is some of the most inspiring work I've seen for our community.
I fully agree with what Dr. Warsame said, that it's reassuring based on the numbers of people who took part in the trials and the demographics of the people involved. And I'd also say, it's tough, right? It's tough to trust when you know you've been hurt before and your people have been hurt before. And we know that, all the effects of the structural racism, we see them all the time. I'd mentioned earlier that I do health disparities research work. And even just looking at our population that we see here, with diabetes, I know that patients of color have poor outcomes, and I'm even so afraid because with the pandemic that has gotten worse. And I forgot to say, when we're talking about what to do to take care of your health as we await the vaccine, remember to get your usual, medical attention for your diabetes, for the hypertension. But to go back to this question about trust, that it's real and we see it all the time. And I can say it's one of the things that I have thought about a lot and wondered, how do we really make a change that is lasting? And that's not window dressing. And that's really talking about it and being frank. And from the medical point of view, owning that, knowing that I'm really part of this system and it's now that we have to start to change. But here's the thing, we cannot really change without the community. We cannot change without the people that we're trying to serve. And it's really engaging with people. And I know some of my colleagues who do work in the cardiovascular space, Dr. Brewer, La Princess Brewer, has done a lot of work going to barbershops, going to faith communities. Because if you're not involved in the point of discussing, this is our problem and this is how we think we can solve it, because we as communities also are very resourceful. We know what our problems are and we have ideas of how we can help the medical community solve them. But of course, then as a medical community, we have to listen, but then we need everybody on the table. So there is no easy answer. I think one of the real things that you see, we as medical professionals trust the vaccine. So Dr. Rashidi had shared at the beginning that, within Mayo Clinic, it was an opt-in. We were not forced. We were not told that you have to get this vaccine. But I look at my colleagues, at least within our division, we were talking about this yesterday, 90% of our staff have opted in, and almost, more than half have already had their two vaccines. I think it was like 70% have already received their 2 doses. So when you think about it, we've had the privilege of learning more about this vaccine and previous vaccines, and we trust it. And I hope that statement in itself says something, that we think it's a good thing for us to have. We think it's a good thing for our community to have.
Yeah, thank you for that. The other question again was about the trust, and I'll just say that I think we've already answered it. Why is it so important for the Black community to get this vaccine? I mean, we've always been at the bottom, so please tell me. And I think those are things that we've already been addressing. Um, can you somebody and maybe Dr. Wasami, Dr. Njeru, please talk about how communities of colors were included in the vaccine development trials?
So I know for at least the phase 3, I can't speak to the phase 1 and phase 2 because those were much smaller trials, but I know that there was intentionality, recognizing, I think it wasn't until maybe it was May when it started reporting who's actually getting it. And we saw that there were certain communities that were clearly disproportionately getting it. And it was communities of color, people in low income, people indigenous, people in rural areas, really far removed that didn't have access, and meat packing plants. And there were just Hispanic Latinx communities. So, but by phase 3, I looked up every site where they were enrolling. Like, I cannot tell you how much I watched this vaccine and the process. I followed who was accruing. I looked for interim analysis. I'm a cancer doctor. I am not a vaccine doctor. I do not have a PhD in immunology, which now I really wish I did. But it was incredible. You saw grassroots opportunities. You could sign up, you could call in to try to get on. Not only was it online, they tried to make it like break down these barriers, because online is also its own limitation. Not everybody has continuous access. Not everyone has devices. I've just been very impressed with this trial, and I really give credence to the fact that people were screaming from the rooftops. Like, I don't know. Last year, I feel like I found my voice, and I'm never going to shut up now about structural issues and problems. I'm just going to be that gal who's just like, so just bringing this up, just wondering about this. Can I push back? And also, I just want to leave you with this note. I'm a refugee. I came from Somalia, and it is such a privilege to have access to this vaccine. Like, I can get emotional because we live in America. And when we get access and we have that privilege, we have to take it. We cannot hold ourselves back because we're afraid. Because there are billions of people who are trying to get this. And I cannot tell you how privileged I feel. I feel like, doctor, to get access even earlier, I would have waited if they said that there was but just to be able to be first and to get in line and to get it, I feel an honor and I feel a gratitude, and I will pay that debt by going happily volunteering to vaccinate if we end up getting enough to go 24/7, I will do second shift. It is a privilege. And I just want to stress that to you. Like, let's take away the science. Like, this is killing our families. This is destroying our economies, and we are disproportionately losing jobs. We are disproportionately becoming homeless and evicted and destroying literally decades of growth. So I appeal to you to really recognize this privilege, because we don't often have privileges, but this will be one of them, and we should take it.
You know, I don't know how I can top that, but I was just gonna completely agree with what you said, Rama. So my parents live in Kenya, and you know they are older. They have got chronic health issues, and I can't even discuss with them the fact that I got the vaccine, because I'm like, why did I get it and not them? So it's really a privilege to be able to get it, and let's not take it for granted, because it's not there for everybody. And I would say that's the call for action for us to take care of our communities. And remember, you know, those people who may not be able to take it because they have an allergy to one of the constituents of the vaccine, those of us who can get it, it's our job to protect them, to get that herd immunity where we're protecting our community.
Yeah, Dr. Wasami, Dr. Njeru, it's hard to follow what you guys said, and I really appreciate just the emotion and just the honesty. I mean, I'm a American Muslim immigrant originally from Nigeria, and COVID is a worldwide thing. It's affecting millions of people. People are dying. And so that's why it's extremely important for the NAACP to make sure that we bring quality information from the top doctors, industry leaders, and that way you guys can make up your own decisions. But that is the intent. So we really appreciate that. We do have some more audience questions. I think we answered this one. So this has to do with the variants. So how concerned should we be about the variants? I mean, we have the UK variant, South Africa. Do the vaccines protect against them? And also, will we need booster shots in the future?
So maybe I could just tackle this one, but I'll be brief because I don't want to dominate the stage. The bottom line is these variants are emerging. The vaccines still work. They might be slightly less effective, but they do still keep you from getting really sick. It appears in 85% of people. The most important thing is that the more people get vaccinated, as was said before, the more we'll stop the spread of the virus, and that will stop the mutations from happening. And it is likely that we will need boosters down the road, just like for flu. Oh, I think you're on mute, Wally.
Thank you for that. So the next question is, what is being done for the homeless community with the vaccine? And so I don't know if Dr. Njeri, Dr. El-Rashidi, is there, from a community perspective, do we know?
So I do not know specifically regarding the homeless community. I know that there is a lot of work going on, with collaboration between Mayo Clinic, Olmsted Medical Center, Olmsted County Public Health to reach everybody. I do know that for testing, one of my colleagues here, her name is Dr. McCoy, actually helped with testing for the homeless. And I know that there is work, but in the planning stages, and just to know that that group is not forgotten.
I think they've, Dr. McCoy has started working with the paramedic teams, and I think they've given their first 60 vaccines to older homeless adults. So I think it's coming.
Okay, that's great. While the vaccine is encouraged, now, will it soon be mandatory? Will we get to the point where we have to have the vaccine to fly, enter businesses, et cetera?
I have no idea. And
I can help with this one because of my role in MCL. Actually, this is not FDA approved. It's emergency use authorized. So it's authorized for use in a health emergency, which means you actually can't, as an employer, mandate that someone takes a vaccine. It's by law. So and it's going to take a while for that FDA approval to happen. That's why events like this and people understanding why they should get it become more important, because really, because of the nature of the approval process, you can't make it mandatory.
Thank you. Next question is, how should businesses and community organizations support vaccinations? Do employers have a role in encouraging or even requiring employees to be vaccinated? Obviously, we've talked about it's not, it can be mandated right now. But what role should people have in encouraging, in addition to doing things like this? Any other suggestions?
One thing that I think would be really helpful for employers to do is to give employees the opportunity to get the vaccine, and even reassure them, that sometimes you get, more of those chills, the fatigue that you may need to take half a day or a day off work, that should not be a penalty on the employee, that they should know that it's okay for me, I'll get time to get the vaccine and potentially support, and most majority of the time, we're able to come back to work right the day or continue working the same day or the following day. But I think availing the time is critical for especially, some of our communities where it's hard, sometimes you take time off to go to see the doctor, and it sort of counts against your vacation. So just reassuring that time is available, I think would be helpful.
I agree. I would hope to go so far as to allow them to have that time be paid for if they go, like that is in your best interest, so they can keep working for you. And that you shouldn't get sick time held against you or things like that. I think that's what we can do to ensure that everybody has an opportunity.
Next question is, how many of you have taken the shot or are you considering doing so?
I got mine. I get my second one on Wednesday and I'm doing a bone marrow harvest. And because that was the earliest I could get it, I was like, so be it. I will harvest and then get my shot.
I got mine, my first dose. I'm getting my second dose this coming Thursday. My appointment is at 6:30 a.m.
Dr. El-Rashidi?
I got mine, and the first one felt like the flu shot, which was this year was nothing. I'd had a tetanus before and then had a sore arm. After I got my second shot, about 15 hours later, I woke up feeling chills and aches, and I ended up having to take the day. And so I think Dr. Warsami's point of what can businesses do, that is a beautiful, perfect, awesome policy position to encourage in the community. Do not penalize your employees from getting this, because some are going to have those natural reactions. It was short-lived, got done in, by the end of the next day. So it well worth it compared to obviously getting COVID.
Yeah. And Dr. Maurice?
Oh, yeah. Yes, I actually had my second shot yesterday. So, and I put it out there because I wanted people to see it on Twitter. And sure enough, I had some, the Twitter sphere, there are some people that were hating on it, but it's important.
Rachel, Donovan, have you guys had your shots yet, or?
I have. I received both doses as a nurse. We were part of the first groups at Mayo. Like Dr. El-Rashidi said, first dose was just some arm soreness. Second dose, I had not fevers or chills, but just like hot flashes for about 48 hours. But nothing that couldn't be managed with some Tylenol, ibuprofen, and lots of water.
Now, I'm one of those that are kind of clueless, wondering where I fall in the tier system. But since I work for the criminal justice system through the public defender office, there is a thought that we might be in that category because we have to go to court, we have to go to jail to help our clientele. So to some degree, I think we may be on a higher tier, but nothing as of yet. I'm just hiding in my apartment and waiting for my turn. So
yeah. So I know we're running out of time, but there are two important ones. So one has to do with if you've had the virus, should you still get the shot? So everybody is nodding yes, and then in terms of the shot, I haven't taken the shot. I'm not eligible yet, but absolutely, I do intend to do that. So we're not just saying do as I say. We're following exactly what what the advice of our trusted doctors and friends are doing. And then one comment was we need more people of color in healthcare to help build the trust, and absolutely, totally agree. From an NAACP perspective, we need more people of color in healthcare and jobs. Economic sustainability is extremely important to us. Education is important, healthcare is important. So these are all things that we're advocating for, and these are all social justice issues. So I know we're out of time, but just want to thank you all for joining us. I hope that this fantastic panel is actually providing you a more quality information in terms of the science and in terms of can you trust the science and the people, these fantastic individuals. So next week we're going to continue our whole month-long series of events. We're going to have the Minnesota Attorney General Keith Ellison, and essentially he's going to talk about the transformational nature of 2020 and where do we go from now, right? So look forward to joining us there, but really appreciate everybody joining us. And please, if you have more questions, go to our Facebook page or Slido, and then we'll definitely get it to Dr. Warsame, Dr. El-Rashidi, Dr. Njeri, and Dr. Maurice to answer that for you guys. So appreciate the opportunity, and stay safe and stay blessed.
Thank you so much. Happy Black History Month. Go celebrate all our Black gorgeous joy. So have a good weekend.
Thank you, everybody.
Yeah.
thank you.